meeting to order. We're going to hammer out some details, I guess. So I want to thank Senator Hoffman for conducting the, I'm going to leave pretty quick and then monitor this. I may pop back in, but I've just got so much to do down here. And we've discussed a lot of it. There's two main topics today. One is to look at the budget forecast. And Senator Hoffman, did you know there's a surplus in that forecast in our niche?
I did, Senator Abler. Could you help us understand just what that means?
Well, I think we'll dig into it, but I think it might be $1.825 billion. And so if we were going to help caregivers, how much money do you think we would need to do that?
Well, you know, Senator Abler, it's a great question that you put. If you look at the bill that we worked on last year, I believe we were in the $920 million mark, you know, all in. And if you look at over a period of the bienniums, that $1.825 million would stretch a long way, Senator Abler, wouldn't you agree?
Just might do it.
It might just do it.
And we'll discuss it some more, and I'm sure you'll make the point more than one time, as I hear sometimes it bears repeating some of these points, but that money actually belongs to human services situations. It doesn't, with all respect to education and roads and public safety and, you know, whatever needs the mill pond might have, again, to make that even better. That's money to take care of people with special needs and seniors and keeping them getting rides to the doctors and all that. And those systems, as I recall, Senator Hoffman, aren't those systems pretty much on the verge of collapse?
You know, Senator, I'm glad you brought that up because, you know, I can give you, not that we want to legislate by anecdotes, but anecdotally, when you start talking to all the different providers out there, I got a place in Cokato, which is not in our Senate district area, but the fact is they were closing wings down because they could not get the workforce there. And guess where those folks ended up going? You know, they ended up going to hospitals. And I believe, Senator Abler, 20% of hospital beds, somewhere in that niche, are taken up by spaces that could be in some kind of long-term care.
Yeah, and so I think you'll talk about it some more, but from my perspective, and it sounds like yours, that we should deal with first things first, and the $1.825 billion that's underspent and additional FMAP that's come should really go to stabilize this area, and I think you're going to talk about that in time going forward, and as you scrutinize the surplus, and it seems to me that should be the first thing we do, and then we can discuss how to spend the remaining $15.6 billion on other things that are important as well. So anyway, and then we're going to discuss, actually you're going to lead the conversation as the chair designee, and there could not be a better choice for that. So, and to the people in the hallway and those soon to be many hundreds that are watching, I think you're going to be finding this committee in the most capable of hands. The second topic has to do with the 144G niche, but as I thought about it, the jurisdictions for your upcoming committee still aren't established, but even so, those people that are staying in the small ones are the same kind of individuals that we see in our waiver programs and group homes and so on, and it seems they've run afoul of this assisted living licensure, and it's not working, and so maybe there's a way to find different licenses or even set up a special program in DHS for little assisted livings. And Senator Hoffman, you and I neither want to undo the safety situations that have been brought forward by this law on the assisted livings where there were some real grievous problems. We're not trying to unwind it. We just want to help these little places survive. So Senator Hoffman, I'm going to tune off and turn it over to you. Anything else you wanted to tell me, or before I go to video silencer?
Thank you, Senator Abler, and thanks for doing the work. Your mom's place down there was just devastated. You know, 2 feet of water in her place, and the fact is
that's a lot, by the way.
That's a lot. You know, that's a lot, and I can tell by what you're doing. But thank you for convening this. And you're correct. We don't know what the jurisdictions or the accounts are, but there's a bunch of but clauses in here. But you got an intertwines of 245D, you got 245G, probably got all the other acronyms that are associated with this, and how are they interrelated and working together in order to assure that services are being met. So, Senator Abler, thank you for calling this hearing, and thank you for all the work that you've done and I look forward to the work that you continue to do.
A lot of work ahead for all of us. So thanks.
do.
I'm going to sign off, and it's all you have the con, Senator Hoffman.
Thank you, Senator
Stay
Abler.
in the Navy, so you're in a stewardship.
Have a great day.
Thank you. I might pop in, I might not. So
All right.
thank you.
You're all good. So, and with that, thank you, Senator Abler. The work that we have in front of us, I mean, this is the most important work that we have, period. And I think, Elise Bailey is here with us, the fiscal director from the Minnesota Department of Human Services. And to the point that Senator Abler does, Miss Bailey, welcome. Nice to see you.
Hello, Designee Chair Hoffman and members of the committee. Oh, happy to be here. I think I will just get right ahead, and my coworker Matt Burdick is going to kind of share his screen to dive right in. So for the record, I'm Elise Bailey. I'm the budget director over at DHS, and I'm just going to give a quick overview of what we're seeing in the November 2022 forecast. So kind of to ground us here on the magnitude of the impact of DHS forecasted programs in fiscal year 2022, we served over 1.4 million people through our forecasted programs at a cost of about $18 billion in total spending per year. And so what you'll see in this forecast is really the change between what we had anticipated in our forecast spending at the end of last session and what we're anticipating now, so the difference. As Senator Abler mentioned, that the magnitude of savings in our forecast is quite large. I would say it's maybe one of the largest forecasts that we've kind of produced of this magnitude of savings. So about $1.184 billion change in the first biennium and $720 million in the second. While it's a large change, I would say that there's four main reasons rolled up into the large change that could explain the savings here. And so they're in that first block. So at the end of the session forecast, we assumed that the public health emergency through the federal government was going to end in April 2022. And that was based on what we knew when we did the February forecast. And so with this forecast, we're reflecting that public health emergency has now been extended through January 2023. And that impacts our forecast because the state gets an additional 6.2% federal matching dollars for a Medicaid program, while the public health emergency is in effect. So we get that enhanced match through the quarter in which the public health emergency is in effect. And so in this forecast, we're assuming, I think, 9 additional months of enhanced FMAP. With that, we also are required to continue our continuous eligibility provisions. So in order to get that enhanced federal funding, states across the country are required to maintain continuous coverage for people on public health programs. And so that's why you'll see a slight increase in spending actually in the second biennium because we are extending those provisions. The second big kind of rolled up reason why we have a significant savings in our forecast is low utilization, and I'll get into the details a little bit later on this, but particularly in our Medicaid nursing facilities and our child care assistance programs, we're finding that there's just less utilization than we had previously anticipated in the previous forecast. The third main reason is we have a decreased average cost in our basic care and our healthcare programs. So we had actuaries do an analysis to set the managed care rates across our basic care program, and they found that the actual cost experience from 2019 to 2021 was lower than the increased trends that we had in the previous forecast. So we're bringing it down according to what the new managed care rates are. And then lastly, we found that between the last forecast and this forecast, we've collected many more pharmacy rebates than we previously had anticipated. So in fiscal 2022, we collected $900 million in state and federal dollars in pharmacy rebates. And this was about 250 to 300 million more than we had previously anticipated in the last forecast. And we're finding that it's likely due to increased enrollment due to the continuous coverage requirements under the PHE. And so with this forecast, we're updating our trends connecting what we receive in rebates to the number of people that are enrolled on our program. And that is partially offset by, we have a sunset of the drug formulary committee in current law, which will impact our ability to draw down some of the supplemental pharmacy rebates, but overall, the total pharmacy rebates you'll see summed up on the first table there. All right, if we could scroll a little bit down, I'm going to go a little bit into detail on the different budget activities that we have in our forecast. So the first block is the long-term care facilities. And as I mentioned, this is really driven by, beyond the public health emergency extension, it's really driven by a decrease in the number of people that we're serving in facilities. But previously, we had expected, during COVID, that at some point, while during COVID the utilization went down, we had anticipated at some point we would have a bump back up to what we previously had been serving, the number of people we previously had been serving, and then continued the trend line prior to the COVID pandemic. But at this point, we are not seeing a jump back up in recipients. And so we're lowering our trends in the forecast to have this new base, this new normal of where we're at, and have the ongoing trend that we always had previous to the COVID pandemic, which was actually a slow decline in the number of people choosing to receive care in facilities. The next block is the long-term care waivers under the Medicaid program. And in this block, we're seeing, beyond the extension of the public health emergency and the change to our regular FMAP, we're seeing for disability waivers a slightly higher number of people, but lower than expected monthly payments. And for home care and personal care assistance programs, we're finding that the growth in the number of people is growing at a slower pace than we previously anticipated. And so you'll see the reduction there. And then there's a few pieces of implementation delays that we've, between last forecast and this forecast, are accounting for. The Community First Services and Supports program, or that the program that the PCA program will be being shifted to, we have now delayed that to the spring of 2023. And so you'll see the impact here. And then the Waiver Reimagine program, we have delayed the implementation of that until 2026. So there's a slight impact in the second biennium due to that. And you'll see the FMAP increased to 51.49%. So we have our standard federal match participation rate from the federal government. That was actually increased to 51.49% in October 2023. So that results in less state dollars having to go towards the Medicaid program overall. And moving on to the next three blocks are centered around our basic care. So and differentiated by the different eligibility populations. So you'll see the elderly and basic care, the overall change is 6.9% here in the first biennium and 1.7% in the second. And then beyond the PHE and FMAP changes here, the largest change that we're finding is that the average cost going down across the population. You'll also see the federal D clawback payments here. So this is for people who are dually eligible for Medicaid and Medicare. And the federal government requires the state to pay for a portion of their Part D prescription drug coverage. It's called the clawback. And the amount of the clawback has been reduced during the PHE. And so you'll see the reduction here in the first biennium. But the charge rate for 2023 increased. So you'll see an increase in the second biennium. Quickly going through MA adults with no children. So this population, because our federal financial participation rate is so high, the enhanced FMAP through the public health emergency is not applicable to this population. And so you'll see actually a cost here with the extension of the public health emergency, because while we're not getting an increased federal match, we are required to do the continuous eligibility provisions. And so that's why you'll see a cost here. And then in addition, we're really projecting this particular population to grow faster than previously expected. And so you'll see an increase there. And that's based on our IHS Global Insight trends of a recession upcoming. And then the MA families with children, our basic care program, you'll see the overall change here is a reduction of 13.7% in the first biennium and 9.2% in the second. And as with the previous population, we're finding that enrollment is growing faster than previously anticipated, but the average costs are down due to the lower than previously expected managed care payments. In here, you'll see the pharmacy rebates that I mentioned earlier, as well as the Merck change. So prior forecasts included MA payments to the Minnesota Department of Health for distribution to Merck providers. And these MA payments were partially funded with a transfer revenue from the University of Minnesota and through a federal waiver. It generated federal financial participation, but since the February forecast, we've been informed that the waiver providing that federal funding will not be extended by the federal government and will sunset at the end of this year. And so as a result, all Merck payments and transfer revenue beyond the sunset date have been removed from the forecast. Moving quickly on, you'll see the Behavioral Health Fund here. Very small changes. The Behavioral Health Fund, as a reminder, pays for residential and outpatient substance use disorder treatment services for people in Minnesota who are low income, and pretty small changes in this forecast. We're finding a slight increase in the second biennium due to higher than expected residential services paid for by MCOs. The Minnesota Family Investment Program, again, a small change comparatively. We're finding lower than expected number of people being served here, but that's offset by a higher average payment. So pretty small change across the board. There's also interaction with our state's maintenance of effort, or what we call the MOE, which is required by the federal government for our state to spend on our TANF program. So while we're seeing a decline in the MFIP expenditures, we have to increase state spending necessary to meet that MOE requirement. The next block is the Child Care Assistance Program. So this program, of course, provides child care assistance to MFIP families who are employed or are engaged in other work activities. This program, as you can see, the big change here is we're seeing steep declines in the usage due to the pandemic. So we saw big declines, and in previous forecasts, we had anticipated that utilization would recover pretty quickly as impacts of the pandemic subsided. But at this point, it's becoming clear that prior expectations of that quick recovery is not being realized. So in this forecast, we're adjusting our assumptions to reflect that recovery will be a lower trend line. And we're projecting lower than previously projected caseloads through state fiscal year 25. The North Star Care for Children program is designed to help kids removed from their homes and to support permanency through adoption or transfer of custody. And you'll see here that we have decreased cost primarily due to fewer people being served in both bienniums. The General Assistance, Housing Support, and MSA, or Minnesota Supplemental Aid, you'll see very small changes here. And the story behind the numbers, I would say, is lower caseloads we're seeing in 2022 and 2023. but generally offset by increases in the average payment in the second biennium. And then lastly, the Healthcare Access Fund. You'll see big changes here as well. To ground us in what the Healthcare Access Fund Minnesota Care Program supports, in 2022, we served over 105,000 people every month at a total cost of $637 million. So you see the change here in this forecast is pretty significant. And basically, it's a result of increased federal funding. So Minnesota operates as the state's BHP, or Basic Health Program. And as part of that, we receive a per person subsidy equal to 95% of the premium tax credits the person would have received if they had received insurance through Licensure. Most of the changes in this forecast are the result of that BHP funding amount going up. So between last forecast and this forecast, we received a notice from the federal government that they would adjust the funding formula to account for the indirect impact of our state operating the reinsurance program. Previously, because the reinsurance program lowered payments or premiums in the private market, it generally reduced our federal BHP funding as a result indirectly. And so this update modifies the funding formula that we receive to not punish the state essentially for running a reinsurance program. And then the second big area where we're getting increased federal BHP funding is that the ARPA, we got a 3-year ARPA extension for calendar years 23 through 25. And one component of ARPA is that it lowers the maximum household out-of-pocket contributions. And the impact of that is because there's lowered household spending on premiums, it will result in higher premium tax credits, to which then impacts our BHP funding. So big changes there. And of course, this is only the DHS part of the Healthcare Access Fund forecast. And so I would point you to MMB on their website. They have the statement for the enterprise-wide. And that swing is pretty big as well. So the projected balance in 22-23 now is $926 million, and then $958 million in 24-25. And once you get out to 26-27, the ending balance is expected to be about $1.5 billion. So that's a pretty big swing than we previously had anticipated with the Healthcare Access Fund. With that, I think I will stop there for questions.
Colby, you seen any hands raised on the internets? No. You not? So if you want to see the report, or not the report, but the summary of what Elise Bailey just highlighted to us, which is a lot of questions, and I'm going to pop them back here in a couple seconds. But if you go to the Minnesota Senate, Senator Abler's committee website, Colby had put all that for people to view. So nobody's raising their hands yet. So Ms. Bailey, Senator Abler, if you have any questions, feel free to turn your machine on. But a couple of things. This really leads to this conversation of redirecting Medicaid, redirecting Medicare, and there's some discussion around different academic ventures about that, and I don't know what it would look like, but I just know this, right? We budget for X amount of dollars, right? That we're making the assumptions, right? Budgets and assumptions. I'm not a fiscal person. I played one in a play one time, Miss Bailey. So the assumptions that we play out there are based upon what we see as a current need, right? And so we can all agree to that. And then for whatever reasons, in this case, I heard you say multiple times, due to the pandemic, right? Which is, lots of due to the pandemic, right? We underutilized, right? And so my first thought is I would like to engage, especially this year, about a discussion of redirecting, because I'm not satisfied that 1.82, well, thank you for the correction, $1.184 billion. I've been saying 1.825, but now it's $1.184 billion. of unspent money that we budgeted. We made the assumption this was going to go to X, goes to the bottom line. And that bottom line, the financial people call it a savings, but I say those are savings that are on the backs of people with disabilities and people most vulnerable in the state of Minnesota. And so I just wanted to get that. The only real conversation is really redirecting, redirecting both Medicaid and Medicare. What does that look like? How should it? So think about that. But then the thing, I guess, question, and maybe I know Christy Grom and Matt are on here too, and maybe we can engage in this and just put it on our queue. When you got the CCAP and nursing utilization, there was less utilization, right? And I want to make an assumption why, but I would rather hear, did anybody report to you why there was less utilized in those places, a workforce shortage? I mean, what were kind of the things that floated to the top?
Senator Abler, committee. I think what I would say is we don't really know why, but generally I would say the pandemic was really challenging to forecast and to understand what the long-term impacts would be and how quickly we would recover, because we don't have historical knowledge on something similar happening in the past. So one thing about this forecast is really modifying how we maybe anticipated recovery looking. So that's one item. I would say we are hearing a lot about the workforce shortage. And it is a concern, and we can see the vacancy rates in this sector being much larger than ever before. So one might want to assume that that is somewhat in this forecast, that there are impacts of not having workers to serve people who need care. But we can't really pinpoint what percent of the impact is that, what percent of the impact is maybe people don't choose to receive facility-based care or are choosing not to send their children to childcare settings because life is somewhat different. So I think that's yet to be seen, but it's a good question.
No, thank you. And I understand, Ms. Bailey, the essence of what you're saying. I understand the essence of that. And it's like, that just bodes to the next, forms of questions. What are we going to do to create some flexibility? We talk about modifying, we talk about putting different things in. It's like, what is needed from legislative viewpoint to allow more flexibility within situations like this? Because I'm still having a hard time, now that I've been corrected, 1.184 billion, I'm still having a hard time, saying that money could have been used, should have been used. What did, where did we all miss on that one? So, and I think if you look back at it, the bill we had last year that passed the Senate, I think 64-1 or 60-4, I can't remember, but it was 60 plus people voted for 66, I guess, and I'm corrected here. We want to redo that kind of work and call it the Caregiver Stabilization Act, really, because you look back at that and say, all right, well, how can we, make this a reality? So the other thing is that, the child care declines due to the pandemic, right? So then, you were hearing about the child care needs, child care assistance. I would hope that everybody across the board is coming to you, and especially when it comes to CCAP and when it comes to, there are some vulnerable adults, vulnerable children within that population that, are you able to, give your advice to the folks that are going to be trying to make some decisions on childcare. And then I guess I have a question for if Matt or Christy. The CFSS is scheduled for April, right? And that's the replacing, that's where the PCA piece is. It's scheduled for April 2023, and I know it's been a challenge to implement, right? Is the department feeling pretty confident on these timelines? There she is, Christy Grom.
Mr. Chair, members of the committee, Christy Grom with the Department of Human Services. We are feeling pretty confident with the timeline.
Good.
We've been working on training and getting some of our consultation service providers ready and making sure that all of our systems are ready for the transition. But we'll continue to work with CMS and keep you all updated on that transition.
Awesome. And so if long as you're there, Ms. Grom, we do need to see a GA increase as well this year. I mean, I want to try to, make sure if I get that jurisdiction, let's work on that. But one of the understandings of the CFSS piece was that we had passed out of this, well, actually it's in law, PCA driving, right? And that it got connected to CFSS. And yet we have this huge gap going on right now. And it's the reason I ask that is, when you talk to people like Jeff Bangsberg, that really are trying to, highlight this going forward, there's this gap. And what can we do to get some flexibility or within that?
Well, Mr. Chair, we have been in conversation with stakeholders on this and really understand where they're coming from. I think, I think their perspective makes a lot of sense to us.
Okay.
And we have offered to provide technical assistance to see if there's anything that we can do between now and when CFSS gets implemented, but also when it gets implemented and when everyone's actually on CFSS, because we know that transition will take approximately a year to get people fully transitioned over.
Because of
so
the
happy to
timelines.
provide technical assistance and see if we can create some flexibilities in the meantime.
Awesome. Thank you. Thank you. And Ms. Bailey, thank you. I don't see anybody raising their hand for any other questions, but thank you for this outline. I look forward to our conversation on redirection, redirecting or whatever, redirect Medicaid, Medicare, that conversation. What does that look like? So thank you for this update. I appreciate that. And thank you, Ms. Grom. So we're going to transition. Colby, is there anything else? Nothing that, anything added to this agenda other than just we got a couple of people. It looks like there's a couple of folks that are going to be zooming in on the presentation, but everybody else is here, correct? And so thank you, everybody. The 144G discussion last 2 weeks ago prompted some other conversations, right? There's this bucket, I'm going to call it a bucket of multiple things moving at the same time. And the things are, I'm talking 245D, 245G, there's probably an A and a Z and a Q in there too. But, and then you got the Department of Health and Ms. Timian was very clear with me this week. I appreciated our conversation about how that is looking. And with that, we have a discussion. Diana Rydrick, did I say that right? You better correct me if I didn't. And Lindsay Kruger, both from the Minnesota Department of Health. Ms. Roderick is the Assistant Commissioner. Do you want to come in and help us? I think you're going to do a little presentation. Just kind of give us that, very distinct, if you could keep it less than an hour. I'm glad you're way less. If we could just get it distinct, because I really want to hear what Senator Abler really talked about. He really wants to hear from folks that this is affecting and where we need to go. So if you could just give us a really succinct and brief overview of what we're dealing with, and then we can have this conversation later on. So thank you. Welcome to the committee, you two.
Thank you, Mr. Chair and members. For the record, my name is Diane Rydrick, and I'm the Assistant Commissioner of the Health Systems Bureau at MDH. And yes, you got it right. Lindsay and I were saying, even though her name looks much more straightforward, people seem to get her name wrong as much or more than mine. So we'll wait for that. So why don't you introduce yourself, Lindsay, and then I'll kick us off.
Sure. Good morning, Mr. Chair, members of the committee. My name is Lindsay Krieger, and I am from the Minnesota Department of Health, the Health Regulation Division.
Awesome. Well, welcome, you two. Welcome. And Assistant Commissioner, I think you're leading the efforts here.
Yeah, Mr. Chair and members, I just want to say thanks for having us here, and it's nice to be back in person. It feels like a normal, if rather empty day, but it's nice to be able to see folks in person and have that interaction. And we dodged a blizzard, sort of, this time. So I'm really just going to start us off, and our short presentation, I think probably only 10 minutes or so, will be Ms. Krieger. And we weren't sure exactly where you wanted us to focus today. We didn't have any questions. We thought it might just be open-ended a little bit, but knowing that there had been a lot of discussion 2 weeks ago on smaller providers, we've focused some of our content on that and provide some breakdowns of licensure and complaints and closures and things like that by small providers versus large, so you can get a sense of the lay of the land. And we've got a little bit of just background information on the law, which I think is also helpful for people too. And we'll talk a little bit about how we'd like to approach some of these issues going forward too.
And with that, Assistant Commissioner, you know, the optics, I talked to Ms. Timian about this, you have multiple agencies intertwining, whether you're talking, you know, the customized living, assisted living, 245, whatever, right? The fact is there's these multiple layers in there, and then how are they interacting proactively? Because at the end of the day, it's the people that we need to be serving that we should be really focused on. So thank you for that.
Absolutely, and I appreciate that call out, Mr. Chair. And we do have at least one slide that points out the issues that MDH is responsible for and DHS, and then also noting BELTS, which is the Board of Examiners for long-term services and supports, which is licensed assisted living directors. So there is an interaction between multiple organizations. And then, of course, as you said, the core of all of this is the residents and the care for residents. And so as part of our ongoing conversations, we are working with the consumer advocates who are also here today, and we're pleased that they'll be able to provide their voice too. So we will definitely talk about that.
Thank you, Assistant Commissioner. Ms. Krieger.
Sure. Thank you. All right, Mr. Chair, so we're going to start with just some background in regards to assisted living licensure. Assisted living licensure was passed in 2019 with broad stakeholder provider support at that time. The intent of the law was to set clear, consistent expectations for providers and more protections for residents who live in these settings. Now, with assisted living licensure, it changed the framework here in Minnesota. It combined housing with services into one license. Previous to assisted living licensure, we had the housing with services separate, which was a separate contract for residents and family members, and then also home care services or their services, which was another contract. And so it really is combining the two for one contract for the residents and families and the providers. Oops. So we have two different license types with assisted living licensure. The first one is over on the left-hand side of the screen. It is the basic assisted living licensure license. Both of the licenses are very similar, and I'll get to the dementia care license in a second. But assisted living licensure in general, like I had mentioned, provides housing and assisted living services for the residents. Now, assisted living facilities may also still provide care and services to residents with dementia. The diagnosis of dementia does not dictate where a resident must live. However, assisted livings in particular are prohibited from having a secure dementia care unit. Now, the second type of license is assisted living license with dementia care. This is a specific dementia care license. Providers who have this license can advertise as providing specific dementia care services, and they also are able to have the secure dementia care unit if they choose to do so. There are some additional requirements for licensing and training and programming to help benefit the residents that they care for. Now, we wanted to provide some data for you just in regards to licensing in general across the state. We have broken it up between the 7-county metro area and then also in greater Minnesota. So you can see on the slide that we have approximately 70% of our assisted living providers in the 7-county metro area and approximately 30% in the greater Minnesota area. So we have just over 2,100 providers that currently in the state of Minnesota. Now, if we look at it by capacity size, this is a breakdown of what we have, and I do have a little bit of a grid over on the right-hand side of the screen that talks about what the different acronyms are down below the bars. Assisted living facility is ALF. ALF-DC is the license with dementia care. Now, with assisted living licensure, we do have a license that is granted, and then within that first year of the license being granted, they would receive a survey from the department. And then if they pass with substantial compliance, they would have a full license granted. So the P means provisional assisted living facility. And so the breakdown, we have for the capacity of residents here in Minnesota is that we do have just under 20,000 in assisted living facilities and just under 40,000 in assisted living with dementia care. Now, I just want to point out here before I move on that this is not the total number of residents in assisted living, but the capacity that is licensed for residents here in the state of Minnesota. Now, moving on to a breakdown between Metro and Greater Minnesota. This is the size of providers in the metro area, and you can see that there is a large amount of small providers which have the resident capacity of 10 or under here in the 7-county metro area, and a large majority of those are in Hennepin County. Now, if we look at the data in Greater Minnesota, you can see that there is a significant difference in regards to the smaller providers with a capacity of under 10. There is under 100 compared to, I think, 970 or so on the last slide. So the landscape looks a little bit different in Greater Minnesota than in the metro area in regards to the size of providers. However, when you look at what it looks like in regards to resident capacity, the resident capacity in the 7-county metro area is larger than the Greater Minnesota, but it's where Greater Minnesota catches up in that aspect because there's larger providers in Greater Minnesota. Now, this was a slide that we had a few weeks ago on the 29th. We wanted to bring it back and just talk to you for a minute in regards to closures. There are some closures here in regards to assisted living facilities. Now, there are various reasons for closures. This is something that is coming from the providers as to reasons for closures, but could be including they're not providing any services. They transitioned into the assisted living licensure, decided that it wasn't for them, and they were going to close out their license. Now, we do also hear of some concerns in regards to staffing and reimbursements, and so I do want to highlight that it wasn't the top the top reason for closure, but that is also reason for closure as well.
Just to help me understand that, the top was reimbursement and staffing. Is that correct? Did I?
No, Mr. Chair, the top reason for closure is not providing any services. They didn't have any residents, and they were going to close their license.
Not providing. All right, thank you.
Yep, you're welcome. All right, so moving on to the next slide. This is a breakdown in regards to assisted living closures by the size and location. And so on the far right-hand side, you can see the percentage closed. And so what we have is for the facilities that were closed, such as more than a capacity of 5. And so when we talk today in regards to our data, is 5 and under or 6 and over here for a smaller, kind of a larger facility. So we have about 4% of the facilities that, of the capacity in Greater Minnesota closed. Now, we do have the 32% in Greater Minnesota of 5 or less, but I just want to refer you back to slide 7, and that is a small number of providers that have a capacity of 5 or less in Greater Minnesota, so that's why that percentage is a bit higher. But overall, if you look at it in regards to what we have for providers and capacity, here in Minnesota, we have about 2% of the assisted living licensure capacity that have closed over the last 15 months or so. All right, and I want to talk for a minute in regards to implementation steps. The Department of Health, the Department of Human Services, and other stakeholders have stayed very connected regarding the licensing requirements and the evolving challenges of this new structure. We do continue to think about ways of how we can uphold and retain the protections for the residents, but seeing how we can also make the process less burdensome for the providers. Now, we do have, and we continue to provide WebExes, brown bag lunches, newsletters to providers and to the general public in regards to this new licensure, anything that we're finding on trends for surveys or investigations, just for increased knowledge and for education and help provide that technical assistance. We have many different presentations, lunch and learns that we have posted on our website, and I'm going to talk in a minute in regards to what some of our top findings on our citations, but some of the topics that we've had in assisted living licensure are really reflect on what our top citations are to help providers understand how they can better meet the regulations, which ultimately gets back to the care and services that are provided to the residents. So I do want to acknowledge that we have heard of concerns in regards to implementation and just the areas in the statute that have been harder to implement. And so I want to provide for you on the screen some of those areas of concern that we have heard about in regards to the kitchen and food code. The staffing requirements, we all have heard about staffing shortages, and so the 24-hour awake staffing requirements to help meet the needs of the residents. One of the things with assisted living licensure, as I mentioned before, was the combination of housing with services. And so the license goes to the specific address location of the facility. And so facilities are unable to move to a different address without getting a new license. Assisted living director requirements that Diane had mentioned in regards to going through the BELTS board are an assessment requirements and then reimbursement as well. So top areas of citations, we'll start with the large providers first. And these are some of the areas that are brand new with assisted living licensure. As a reminder, it implemented August 1st of last year, so just about 18 months ago or so. We have physical environment citations including, for example, lack of smoke alarms, broken windows, missing tiles, holes in walls, insect control, etc. Incomplete emergency and disaster planning, especially with COVID-19. This is something that we know is important as we move into the future, including fire drills, evacuation plans, and training of staff on those procedures as well. And then food code violations. And then we can go
Ms.
to...
Kruger, did they, sorry to interrupt you, on the food code violations, was there a breakdown of that that's available, readily available for people to do? Do you know off the top of your head? And if you're not, that's fine.
Mr. Chair, that is a good question. I can get back to you on certain areas of top food code violations.
All right, thank you.
Yeah, you're welcome. All right, and then in regards to small providers, we have some of the very similar areas, such as the last slide, for physical environment, emergency and disaster planning, food code violations, and then also lack of documentation and employee records. So as a reminder, these are some of the summary of the top 5 citations, and also areas and topic areas that we have worked hard to provide more education and information on for providers as well. Oops, go back. So, Mr. Chair, you had mentioned in regards to all the different aspects of assisted living licensure and how there are different departments that are involved with assisted living licensure. So I wanted to provide a little bit of a breakdown here in regards to what the Department of Health oversees, how the Department of Human Services or the county is also involved, and then the Board of Examiners for Long-Term Services and Supports. So anything in regards to licensing, enforcement, implementation of the statutory requirements and the surveys the Department of Health oversees. In regards to any county assessments, waivered service payments, moratorium exception, 245D that you mentioned earlier, that is really overseen by the Department of Human Services. And then we do also have the Board of Examiners for Long-Term Services and Supports, also known as BELTS, and they license the assisted living directors, and they also have rules for those requirements as well. So I just wanted to highlight that for you. And then I will turn it back over to Assistant Commissioner Rydrick to finish us out.
Thank you. I get the easy job of starting and ending the presentation. I just wanted to note, you know, Ms. Krieger mentioned that we do a lot of education for providers around, you doing webinars and brown bags and things like that. And we continue to do that, and we try to have survey findings and questions really drive the education that we provide. it is challenging sometimes. I think especially for smaller providers, they're just busy doing the work day to day, and you can't necessarily always make time to attend a webinar and do a training. And so we are open to other ways to do that, because I know that kind of education where people have to come to us and make time may not always work for some providers, especially when they're really kind of in the thick of it. So we are open to whatever may work better than what we've been doing, but we plan to keep doing what we've been doing. We also have been talking internally about the need to kind of formalize some of these discussions around smaller providers in particular. And now that we are nearly 18 months into implementation, I think it is time to look at whether there are modifications that might need to be made so that we don't have quite as much of a one-size-fits-all for all sizes of providers, and look at whether there are tweaks that need to be made to the statute to accommodate some of the needs that we've been hearing about. So we've had really high-level discussions so far with some of the consumer advocates, and have given a heads up to the providers as well, just to say we would like to convene some conversations around that with all of the stakeholders around the table, and consider where there might be places where we need to work with you to consider changes in the coming session.
So would it make sense, Assistant Commissioner, not to create a blue ribbon panel? Come on, my wife told me don't try to be funny. You're not funny, but I'm not. But in all seriousness, this has got all these different lanes approaching. And, I know this is topic to incoming majority leader Carrie Dietzig, Mahmoud Noor, who is over in the House, and then the incoming vice chair here, Omar Fateh. And it's validated why that is, because Hennepin County happens to have a large amount, right? It's like, well, maybe this is worthy of a discussion, and maybe we should talk about how that could look. I don't, when you do a y'all come, everybody does their little works on the board, but really, if we're going to get to the essence of what really needs to be done and be very succinct about what it is that we should be doing, let's think about how that could look. And it could be smaller groups of individuals picking where their expertise are.
Yep.
And I'll give you an example. A neighbor, Susie Scheller, she's here today. She looked at this system and put together a book. It's like, I want to see that book, right? I mean, that's the kind of thing. It's like, all right, and so kind of think about how we could do that. And maybe I'll ask Toby Pearson and everybody else the same way. How could that? Because if we're going to do this, we should be doing this jointly with Noor. If our jurisdictions line up, I mean, again, if they don't, then we'll figure out a way how we line those two jurisdictions, because clearly your overview shows the health versus human service side of it. So I appreciate that.
And I appreciate that, Mr. Chair, and we have been thinking about that. And one of the things we've already started doing is, we are not the only state to have assisted living licensure. In fact, I believe we were the last to implement assisted living licensure. Other states have also dealt with variations of this issue of how do you accommodate the needs of smaller, almost residential type providers and larger providers that might have 100 residents. And so there's a lot we can also learn from what other states have done and kind of evaluate that. There are states that have not two-tier, because that makes it sound like one is, more rigid than the other, but that have different approaches to regulation for different settings, even within assisted living, and we want to learn from that. And then we've talked about how can we get the right people around the table, which includes, I think legislators need to have input into that too, but the provider perspective, the agency perspective, both MDH and DHS, and the consumer and resident and family voice. And it might end up being kind of a smaller version of what we did when we passed the law several years ago, where you've got groups that focus on particular issues or pain points and really kind of dive into that and then come back together to the whole. But I think it's really what's most important for us is that the safety and quality of care and quality of life for residents is really at the center, but that we're bringing all those voices into the conversation.
Yeah, I like that, because it's not personal. It's clearly, you just said it. At the end of the day, are we doing what's we kind of did that when I was the vice chair of the Hennepin School Board. It didn't matter the conversation. The filter was, what's this in the best interest of the youth that we're supposed to be providing that support for, right?
And the other thing I would note, and you mentioned this in your opening comments, it's not just about assisted living, right? There are other license types. There are other pathways for reimbursement or licensure that may be the right fit for some providers. And I think that's part of what we've seen in Ms. Krieger's data, too, around closures. sometimes a closure doesn't mean the end of services. Sometimes a closure as an assisted living means that an organization has decided there's a different path for them and a different type of license that's best for them. So we have to have that context part of the discussion too.
Good, thank you. And thank you for being open to the greater discussion. I think that gets, gets to where we need to be. So thank you too, I appreciate that. So there was no hands raised? Urgency, wow. Toby, Fortuna Med, I guess, if you want to maybe come down and, it looks like we got basically an hour of discussion, and if Assistant Commissioner, you're going to be hanging around in case, maybe there's some light bulb moments here that we can fix this, right? Should we just get tables and chairs? Should we just sit around and get this? We got Matt, we got Bergeron here. I mean, you got enough people in this. Counselor, you could get going. Mr. Pearson, nice to see you.
Good to be seen, Mr. Chair. Always a pleasure. I believe Fartun is via the interwebs, as you refer to them, so I will start and then be handing it over to her. Mr. Chair, members, my name is Toby Pearson with Care Providers of Minnesota. I will be joined by a couple of providers, and then Ms. Chaprin from Leading Age will kind of wind up the long-term care imperative testimony.
So just so I understand, so Mr. Pearson, you got Fortuna Med, Anna Petersmeyer, and then Libby Chaperon? Is that?
Chaprin, yes,
Chaprin.
That's correct.
Awesome, all right.
And I believe Anna is present.
Right here.
Yes.
Oh, well, welcome, Anna.
Thank you.
Mr. Pearson, the table is yours.
I'd like to thank the department for coming up and giving a brief history. We wanted to go through just a very succinct kind of perspective of ours in that history. In 2019, when the legislature passed 144G, it also seemed that stakeholders had kind of agreed to a couple underlying principles. One, ensure safe, quality services for seniors and their families. Two was to protect seniors' choices and their independence in decision-making. And three was to establish transparency and accountability. I would add that additionally, the provider community repeatedly raised the importance and the value of ensuring affordability and access to those services for Minnesota seniors. We also knew that the law would need continuous improvement as implementation rolled out, and I'd just like to take a second to say kudos to the Department of Health. They rolled out this licensure in the middle of a pandemic when I know all of their staff was overworked, working way too many hours from my perspective, but they did it, and they did it very well. So thank you to all of the department and the staff who did that. But as the implementation rolled out and the stakeholders would develop a better understanding of the licensure's law impact, we needed to readdress it, and that time is now. 18 months into the new law, 3 years after it passed, and during the pandemic, it's time to revisit where Minnesota is holding up to those principles and where we have room for improvement. We know that licensure law is especially burdensome for our small residential providers. I will add anecdotally, it was repeatedly raised, although I think everybody around the table to a certain degree underestimated the exact scope as known, as kind of demonstrated in the slides by MDH. Everybody knew there was a large number of providers that were smaller in size, but I don't think we fully knew exactly how many there were. But it has become increasingly burdensome for those providers, and the reality is that meeting the requirements of the law make the ability to offer affordable services nearly impossible, adding that the elderly waiver has not increased much to accommodate the costs that were implemented during the pandemic. We know that we have serious staffing shortages across this sector, including assisted living, yet the current licensure law has incredibly rigid requirements that are placing additional barriers to getting caregivers to work, allowing them to work at the top of their scope, and frankly, compensating them for fairly serving our seniors with dignity. As I said in the start, we have a couple members here to actually tell their story, and they are prepared to provide their direct experience. thank you for your time, and I will stick around for any questions, but I will turn it over to Fartoon for her testimony.
Thank you, Mr. Pearson. I just wanted to, you had mentioned seniors like 3 or 4 times, but that, from your perspective, seniors, but I just wanted to make sure that people in the interweb world are listening, that the assisted living licensure just isn't about seniors, but that's just from your
Yes, that's
perspective.
correct. There are a number of providers who also offer services to folks who would not technically be in the senior category, but are
Thank you.
probably receiving waiver-paid services. And I think there's an increasing kind of nuance between them, and I think our testifiers will get to that point. So thank you.
I'm looking forward to that. Thank you, and thank you for explaining that in a little better detail. So, Fartoon, Ms. Ahmed, are you there?
Yes, does everybody see me? Good morning.
We do. Welcome to the committee.
Thank you. We are actually one of those providers who don't necessarily serve just seniors. But good morning, Mr. Chair, members. My name is Fartoon Ahmed, and I'm the Assisted Living Director for Stonecrest Living. Stonecrest Living has 7 facilities that range in size from 11 units to 5 units. We serve adult males with chronic mental health needs. Having gone through the licensure process in the middle of a pandemic, we are very aware of the challenges and opportunities for improvement for providers and residents. There are several current requirements that I would like to raise that are in need of a fresh look from advocates, providers, and the Department of Health. I'll start with, first, to address the workforce shortages with flexibility on resident assessments. The current statute and rules require registered nurses to complete all required resident assessments. That means an initial assessment as well as reassessments no later than 14 days after initiation of services, upon a change in a resident's condition, and routinely every 90 days after the last assessment. As a current registered nurse myself, I have seen firsthand the difficulty in meeting assessment deadlines while working through a workforce shortage. Like all healthcare providers, assisted living facilities are facing a severe shortage of RNs and are seeking to maximize the role of licensed practical nurses as one means of addressing this shortage. Second, food code exceptions for small residential settings. Currently, all assisted living facilities, regardless of size or type of setting, are required to meet all the applicable requirements of the Minnesota Food Code. As a smaller provider, the requirements have been cumbersome to meet at each individual facility. For example, every facility is required to have a certified food manager. The certified food manager can only serve one facility, thus requiring us to have 7 different certified food managers at Stonecrest. This is only one example of how difficult it has been for smaller providers to meet the Minnesota Food Code requirements. Experience with assisted living surveys conducted to date have shown that some of these requirements are creating challenges for assisted living facilities that operate small residential models of care in residential homes, such as Stonecrest Living. Third, portability of orientation to assisted living licensure requirements. Assisted living facilities are facing severe workforce shortages, and it is important that providers are able to onboard new employees as quickly and efficiently as possible. All staff providing and supervising direct services must complete an orientation to assisted living facility licensing requirements and regulations before providing assisted living services to residents. But the law states that that orientation is not transferable to another facility if the employee changes jobs. At Stonecrest, if we want to utilize staff throughout all of our 7 facilities, we have to onboard staff 7 times. Imagine that. Thank you for your time and attention. After the implementation and some experience, we ought to be able to take a fresh look at the assisted living licensure requirements and make the changes necessary to keep moving forward. Thank you for your time.
Ms. Ahmed, thank you very much, and those distinct points are well taken, and it seems, yeah, in my mind I was going, well, if this was a 245D place, that wouldn't be the same discussion, so it's like, I appreciate this. It gets us conversing on that. So, Mr. Pearson, you have Ms. Petersmeyer. Petersmeyer. Welcome, Ms. Petersmeyer.
Thank you, Mr. Chair, and thank you to the committee. My name is Anna Petersmeyer, and I am the Chief Operating Officer at Vista Prairie Communities. I'm also a licensed social worker, and I hold a master's degree in administration. and I've worked in the senior healthcare industry for over 20 years. I also can offer a unique perspective in that I am the family member and a primary caregiver to my 92-year-old father who lives in an assisted living south of the metro. Vista Prairie Communities is a nonprofit organization. We operate 7 assisted living communities, 5 of which are in outstate Minnesota. Our geography ranges from Alexandria down to Redwood Falls and Fairmont. Our corporate office is located in Champlin. We employ about 450 employees and serve 900 seniors and individuals with disabilities. And we've just celebrated our 25th year in operations. I'm here today to describe some challenges and some experiences that licensure law have created, but first, I think it's important to share an example of how we as a senior healthcare organization have been able to move forward with innovation and technology that improves the residents' safety while doing that in an affordable manner. Like most businesses, we face significant workforce challenges. Vista Prairie Communities is particularly challenged because we operate in small communities, and the workforce pool there is relatively small when compared to the metro area. In a strategic effort to be innovative, we are developing and deploying a new technology that will allow our teams to be more efficient with time and service and provide a higher level of safety. Next month, Vista Prairie Communities will launch a new technology called Care Predict. Care Predict is a wearable device that will take the place of our call pendants, and it's one of the few technologies in existence that allows our staff to have a two-way conversation in real time with our residents. It also will detect falls, and it uses artificial intelligence technology to identify changes in usual behaviors which typically indicate a potential health concern. I bring this up because it's an example of how senior healthcare operators are using innovation and technology in light of a pandemic and in light of workforce challenges. And we do this in an affordable manner. That affordability is being challenged by the certain challenges of licensure that have created for us. As a nonprofit organization, we serve many Minnesotans, and many of them receive elderly waiver or CADDY waiver. CADDY waiver is the community access for disability inclusion, and it's typically used for people who are under 65 who have disabilities who live in our facilities. Last year, Vista Prairie served 26% of our total Minnesota resident population under these waivers. That relates to a $3.4 million service charitable giving. So meaning $3.4 is the difference between the cost it took us to provide that service against the reimbursement that we received for that service. It's important to us that we follow our mission and we serve all of the Minnesotans who live in our communities. That is threatened by the increased costs and administrative burden that licensure is creating for us. Since licensure, our fees have almost doubled, which relates to tens of thousands of dollars. And on top of that, as my predecessor talked about, the administrative burden and the cost increase, it just takes to do what we would consider normal, practical care. These increases in expenses are diverting the funds from the care delivery for seniors. They're diverting the funds from potential wage enhancements. They're also diverting the funds from potential and needed capital improvements to our aging facilities. So we deeply urge the legislature to revisit the statute. It's simply not meeting the intended goals: safety, quality, and affordability. And we hope that this revisit can create change. And I'm happy to hear from the department that they're open for conversations with us as providers and future deep collaborations.
Thank you, Ms. Petersmeyer. I appreciate you coming all the way from Zealand Avenue in
Yes.
beautiful Champlin, Minnesota. Isn't that amazing, Susie Scheller? There's a Champlin. You have 3 Champlinites right here. So Thank you. And you know, that the discussion, it's absolutely, it's going to take all of us to figure this out, right? I mean, it's just time to, all right, let's fix what we need to be fixing, because, you know, to focus on who it is that we need to be there. So, welcome.
Thank you, Mr. Chair.
Nice to see you again.
Nice to see you. My name's Libby Chaprin, for the record, and I am with the Leading Age Minnesota here on behalf of the Long-Term Care Imperative. Just wanted to summarize a few thoughts, but before we do that, I want to thank you, the body, the Senate, for just prioritizing seniors, prioritizing care, and your leadership on this issue throughout the last legislative session, and we look forward to working with you in 2023. As it relates to 144G, I want to reinforce what you just heard from the provider community. Along with stakeholders, we sat at those tables in 2019 to pass that law and worked tirelessly to find solutions that would promote quality, promote safety, and person-centered care. We understood at that time that our work wasn't complete, that it wasn't perfect by any stretch. So we expected, essentially, that we would have to revisit different aspects once we implemented this law so that we could make sure we're serving seniors and others that are encompassed in the assisted living licensure statute to make sure they have that safe, quality care. And we've learned a lot of lessons since implementation. First and foremost, I think you've heard it here today, is that it's not quite working right for those small providers. These laws that were, quite frankly, designed with larger providers in mind, don't work for those smaller providers. The administrative burden makes it very hard to serve in that model of care where there's small residential settings. You likely know, we know very well that we also have a very significant staffing shortage. We knew that walking into those negotiations in 2019, as did the legislature. What we didn't know is that the pandemic was right around the corner and the staffing issues would be exacerbated. We have over 20,000 open caregiver positions in long-term care alone. And the burdens that come with this law are making it more difficult to get caregivers into work, to keep them at work, and to allow them to practice to the top of their scope. There are a lot of other examples of how some of these regulations, as Fartoon mentioned, that are preventing us from using our workforce to the best of their ability. And last but not least, we just want to say that we know there's opportunities to improve this law. So we're ready and willing to work with you and other stakeholders to improve the licensure law as it stands today, to work for seniors so that we can continue to provide safe, affordable, and quality care in these settings. Minnesota's home to 1 million seniors as of 2022, and we know that they're going to need care. There are additionally other needs around the state, not just amongst seniors. So we have a responsibility to make sure that this law works for them. I just want to close today by saying that Anna and Fartoon and all of the other individuals working in these assisted living settings, I want to thank them for giving care and implementing an assisted living licensure law during the pandemic. We are so grateful for everything you've done, and we're honored to speak on their behalf here today. So thank you for this opportunity.
Thank you. Thank you. Any questions in there, Kobe, Kevin? It sounds like Assistant Commissioner, we're going to have, this is going to be a nice conversation. What do you know? What are we hearing here? What can we do to get this? Yeah, I mean, we'll come up later. You can come up later. We can talk. I'm smiling. I'm looking at you going, all right, the right people are here today to have this conversation, and I appreciate that. So thank you three for being up here, and thank you. Miss Susan Scheller, Miss Susie Scheller, Counselor, is anybody coming up with you, or are you just you? Just you? Listen, Kristen, if you guys want to come and hang out, I mean,
that way.
And then, yeah, I think Ms. Sundberg, and then it looks like Cheryl Hennon and Aisha Elmquist are online. I don't see Mary. Is Mary Jo George around?
She's online.
Is she? All right. So go ahead, Ms. Scheller. Welcome.
Thank
Nice
you
to
so
see you.
much. Nice to see you as well. Mr. Chair and the committee. I'm here to support assisted living licensure, but also to support a broader conversation out of high respect for the Department of Health, the Department of Human Services, providers, as well as residents who are all working together to try to provide quality care for those in our long-term care facilities, whether in the disability community, in the aging community. We are working together, and I have a high respect for that, and that's why I'm here, because I'm passionate about that issue. And as we've talked and discussed, there's always room for improvement. So the first thing I want to highlight is we've heard from the Minnesota Department of Health about the assisted living licensure, where the providers are talking about 144G. Where I see this intersecting with DHS and the broader conversation is particularly in our waivered programs, and how the waivered programs that are traditionally DHS-led intersect with the caregiving licensure in MDH. So I want to just take a brief moment to highlight that extensive history of development of 144G, because it is certainly with a lot of thought. And so we have the Minnesota Department of Health having a significant increase in maltreatment reports in our long-term care settings, coming to the legislature 2016, 2017, 600% rise in those reports of maltreatment over a period of years. And so we have what we saw was a real need. We have Governor Dayton appointing in 2017 a consumer work group to say, how can we address these concerns of suspected maltreatment and care concerns in our long-term care settings. Out of that, Governor Dayton's commission, the group recommended assisted living licensure. We started hearing we're the only state in the country that does not license assisted living. We had the 2018 Office of Legislative Auditors report that recommended assisted living licensure. We had the Minnesota Department of Health engaging in months-long stakeholder groups in 6+ arenas to say, what are the problems, how can we address the problems? All at the table were engaged in that conversation, including providers and consumers and advocates. We had the 2019 law that came out of that. So I want to just take a moment to highlight the extensive stakeholder discussion that brought us to where we are today. It is not the time to reverse course on assisted living licensure. We need to have continued discussions, but that license was put in place for some very good reasons, and it's very important. We have the road to create the assisted living licensure that was well vetted. So it brings us to today. We have the two types of license. We have most of those housing with services registrants actually did then apply for assisted living licensure. I will just speak for myself to say I was surprised that some actually applied for assisted living licensure, such as some small providers. I thought maybe it would be a 245D license that they might go towards. I understand there's size restrictions and some other limitations that perhaps caused the course of action for some of those providers. So it is worthy of discussion, but I want to remind us that maybe that discussion has to come with really drilling down with those small providers. We've heard 3 concerns about assisted living licensure. But what are those concerns for those 1,000 smaller providers in the metro area? They are perhaps used to the waivered programs. They're perhaps used to that. How are we addressing, what are the concerns and how are we addressing them? And does that mean we have to change assisted living licensure? I'm not sure that is the case. Maybe there are some tweaks. It's a broader conversation. But I'm concerned that we would take something that was well thought through and then say we need to adjust licensure, whereas we may need to adjust other things like education, training, and is this the right fit for those providers? I'm not certain of those answers. So there's a lot that has gone into this. The review is ongoing. As with any proposals, there's tweaks. They do involve DHS. The small provider conversation necessitates involvement with DHS. Also, the exempt setting conversation necessitates involvement with DHS. And in general, equitable funding, equitable staffing, equitable pay is a significant topic of conversation. What I am seeing as clients call me representing people in the community who have concerns, they are experiencing that short staffing as well. But when we see assisted living licensed entities, I've got numerous calls of people who are in hospitals not able to get out because they don't have a place to go, and that's a significant problem. But they're looking at these small provider assisted living license group to provide services, and it may be a good fit, but it may not be. And so that's where I get concerned on the back end, that we have good understanding of what the providers, what they're intending to offer, and what monitoring we have of that. So what I urge is maybe not necessarily just looking at the needs of the small provider, but the complexity of the residents' conditions coming into that facility. Because when we were looking at assisted living license, we were looking at the complexity of needs that were currently present in assisted living to a large extent. And so I want to make sure we're looking not just at the size of the provider, but the complexity of the resident need. And that's partly where this 144G and the regulation or the monitoring has come in, is so that we have eyes and ears on behalf of the people we serve to ensure that the facilities are offering what we need them to be offering to meet the needs of residents. So it's a broader discussion. In conclusion, it's not the time to reverse course, but additional discussion is certainly helpful and necessary.
Thank you, Ms. Scheller. I'm kind of hearing that thematically, that people are saying it's just time to have that discussion, right? And you laid it out, just all the complexities of what we dealt with. And thank you for the history lesson, 5 years. I remember that. I remember the conversations that, what we did. And I'm wondering, one of the things that Senator Abler just asked about was, and maybe Assistant Commissioner, you have this, that maltreatment reports based on size. Do you have a breakdown, or did you, in your looking at, you had mentioned maltreatment reports, did you see, is there a breakdown of maltreatment based on size? Do you know?
I can let MDH speak, but this highlights one of the difficulties with a housing with registration system. We didn't necessarily track resident capacity and be able to have that breakdown. They're able to have that breakdown because of licensure.
Right.
So they could maybe correct me in that, but.
No, thank you for that point. I mean, and clearly, if Senator Abler is listening to that, that again has got to be added to our ongoing conversation on this one. It's like, well, what is the, and I'm going to use this term again, essence. What is the essence of all this? I mean, what is it, what we're trying to accomplish here, and what is it we're trying to get to, and stay focused on the unique needs? And it's sad to hear that you're getting calls, folks want to get out of the hospitals, right? They're in the hospitals. We know that the bed capacity in the hospitals, because there isn't the capacity, or there isn't that inventory of places where people can go in the community. So thank you. I look forward to having you work through and with this on this process going forward. Any questions for Susie? No? Seeing none. Ms. Sundberg, welcome.
Thank you. Thank you, Mr. Chair, members of the committee. We appreciate this opportunity to talk about the significance of the assisted living licensure law, which addressed the care crisis that we had going on in 2018, 2019, and frankly, much earlier than that. And we still have this same care crisis happening today. I'm Chris Sundberg. I'm Executive Director of Elder Voice Advocates and Elder Care IQ. We advocate for the quality of care for approximately 40,000 residents of assisted living and 25,000 residents of nursing homes. It's important that 144G was passed in 2019 because of the serious harm being done to many living in assisted living throughout the state. Up to that point, we were the last state to license assisted living. We thank you all. You all came forward, helped us. The providers came together with the advocates and the agencies, and as Susie stated, we worked hundreds of hours, actually, to develop the legislation, which was thoughtful, and it also encompassed a lot of compromise. Now we have a law that took us from being embarrassingly lax in our oversight of assisted living to one that now shows its values and well-being of elders and vulnerable adults. Part of the reason RN assessment was put in to this legislation is we were seeing far too many people being brought into an assisted living facility without really any in-depth knowledge about the care needs. And then finding after a few days only that the facility wasn't capable of meeting those needs. So the RN assessment has been very helpful to us. The 24-hour awake staff protects people. There are often health emergencies, and a sleeping staff person's not able to address that. Unfortunately, we are still seeing excessive levels of abuse, neglect, and exploitation, which is largely being driven by understaffing and the staffing crisis. Too many have suffered long, painful deaths or had limbs amputated because of untreated infections, ignored emergency conditions, or the failure to give basic care. Additionally, many are malnourished because they're not being fed enough nutritious food or given the necessary assistance to eat. Others report sexual assaults by other residents and sometimes even staff. There are also many instances of broken bones, bruises, festering sores, abrasions that are the result of physical abuse, mishandling, or neglect. In other cases, residents have been left for many hours without being moved, fed, given water, or kept clean. Cruel treatment is often reported, such as hitting, insulting, belittling, scaring, and other humiliations. It is clear that the care standards and protections of 144G are vitally important to elders and vulnerable adults. Now, Elder Voice agrees, we have a staffing crisis, but more importantly, we have a care crisis. Let's never keep our eye off those who are most impacted by staffing shortages, and that is the elder and vulnerable adults living in assisted living or other long-term care facilities. We welcome an opportunity to work with the long-term care industry, the legislature, agencies, and other stakeholders to find workable solutions for the staffing issues. For instance, we must look at reimbursement rates. Are they adequate for the providers? It's important, however, that in a verifiable way, any increased funding goes to the increased wages, benefits, and training of the direct care staff. We should also consider livable wage initiatives. These are demanding, stressful jobs, and direct caregivers need to be fairly compensated. The issues driving staffing shortages are complex, but together we can find solutions that improve the care of elders and vulnerable adults, better support the direct caregivers, and allow a fair return for the providers. Thank you for your time, and let's all remember we're elders in training.
I love that. We are elders in training. Ms. Sundberg, is that, you shared that, your letter, people shared their testimonies and their comments with the committee, correct?
I'm sorry.
You shared electronically your.
Yes.
You did, all right,
I'll be
thank you.
happy to, yeah.
All right, I just want to make sure, and Ms. Scheller, and folks that had done it, I would like to compile that. So I don't have any follow-up questions. This is good. Thank you, you two. I appreciate you being here, and thank you for your input. And that leads us, I think, having Ms. Hennon on after your comments, our ombudsman for long-term care, our state ombudsman for long-term care, Cheryl Hennon. Welcome. You heard the comments. Help us get some synergy behind this question that sits out here regarding 144G. Nice seeing you, by the way.
Thank you. Good morning, Chair Hoffman and committee members. I appreciate this opportunity to be before you today. I wish I were there in person, and look forward to further conversations. And the support that's been given to the Office of Ombudsman for Long-Term Care. We provide in-person, statewide presence. The voice most important here is the voice of the residents. And in the sake of time, we will hope to continue this conversation, which I'm sure that it will. Senator Hoffman, you earlier made a comment about the Blue Ribbon Panel. And I feel that what you are suggesting is what we need to do next. Many comments have been made by previous speakers that I can attest to. It's in our complaint investigation work that we have. We walk at the side of the very people that all of us need to be concerned about, the residents. The staffing crisis, for example, we see in our data how quality of care is affected, and we are receiving numerous complaints about neglect, lack of proper care, and abuse. So there are many contributing factors to this, which all of us have heard about. Again, our office is in a unique position to speak about how assisted living licensure is impacting residents. Having received well over 2,000 requests for help to date related to assisted living since this law was implemented August 1st, 2021. The assisted living licensure law has provided a foundation of standards and minimum requirements that was much needed to ensure the health, safety, and well-being of Minnesota assisted living residents. And we have numerous examples of where this law has benefited residents. But back to a comment or a suggestion that you made, Senator Hoffman, I believe I want to know more about the specifics about these concerns. Small providers, and I also hear from providers that are providing care to many individuals, many different levels of care, many different ages. We are also seeing the increase in acuity levels. I served on, maybe there may be others that remember the Yellow Ribbon panel at what that was brought together. We were looking at the veterans homes governing structure. Yeah. So I feel like we've done it before and we can do it again, that we need to come together and do this thoughtfully and respectfully to really figure out and define these problems and what are the recommendations, which could lead to accommodating changes in what we have in place, but to always remember that the changes cannot be changes that would harm or potentially harm residents. So I want to turn this over to Aisha Elmquist. She is a deputy in our office, and I want her to be able to share with you a few additional testimony here. But again, Senator Hoffman and other committee members, it's imperative that we figure out how we all get at the same table and figure this out together for the benefit of residents. Thank you.
No, thank you. Ms. Hennon, it just dawned on me too that, you know, Bud needs to be having this in this.
Right.
We're
right.
Again, we got this bucket of 245s, whatever, to 256Bs, all right. And it's like, well, you know, because it's not just, now that assisted licensing is larger, then it's not just, you know, seniors, but we're also talking about people most vulnerable, BI, CADI, those types of waivered services. So you'll connect with Bud, I would assume?
Well, Senator Hoffman, I really appreciate your commitment here, and you are exactly right. In fact,
yeah, why don't you say that again so my wife hears you say that? Exactly right. I'm kidding.
You have been steadfast, as well as Senator Abler and other people on your committee. So yes, I have, and when we say but, for people who may or may not know, Mr. Rosenfeld is the state ombudsman for, that's okay, for mental health and developmental disabilities. We work with them collaboratively. He does know, I did ask him if he was going to be here today and he was unable to be. So I will reach out to him. I know that he is very interested in this, and we need to get through the confusion. There's so much information out there. Who are we really talking about, and what are the needs and what are the solutions? So with that,
Thank you.
Aisha.
Thank you. Ms. Elmquist, thank you. Welcome to the committee.
Thank you so much. Good morning, Mr. Chair and members. I am Aisha Elmquist, and thank you for having us here today to help amplify what we are seeing and hearing from residents in assisted living facilities, including smaller facilities. As you know, and as has been mentioned earlier, the assisted living law was enacted due to gaps in the protection, rights, and safety of residents. And we have seen significant improvements in many areas due to the assisted living law and ways that we are able to better advocate for residents. To give you a couple examples, in one smaller assisted living facility, we found no central heat, significant fire safety concerns, many serious physical plant issues and care issues. And due to the new assisted living law, we were able to advocate, MDH was involved, and we saw significant improvements. We've also seen examples of people with care concerns, including bed sores related to not being moved as needed, including in smaller assisted living, and have seen progress in that area as well. We've seen protections in allowing people to stay and thrive in their homes. I could give you many more examples, but those examples are important to keep in mind as we move forward. And we look forward to future discussions and ensuring that we continue to preserve and enhance the critical protections for residents as we move forward. And as Cheryl said, we very much look forward to discussions with providers and learning what's working well, what's not working well, and also encourage in those discussions that we look at what's working well and what may not be working as well, or gaps that may also exist for residents. And those are very important conversations for us to be having. So thank you so much for having us here today.
Thank you. And I would assume you're going to be hanging out with Ms. Hennon and in getting a hold of Ms. Budd. So thank you. Any questions? Any follow-up? Thank you to Mary Jo George.
Well, hello. Good afternoon.
Nice to see you.
Yes, nice to see you. Thanks for having us. I'll try to be short and sweet because you've heard a lot already. But good afternoon, Chair Hoffman and members of the committee. My name is Mary Jo George, and I'm the Advocacy Director for ARP Minnesota. I'm here on behalf of the Consumer Coalition, which includes ARP Minnesota, Legal Aid, the Alzheimer's Association of Minnesota and North Dakota, and the Minnesota Elder Justice Center to provide our thoughts on 144G. As you've already heard today from many of the testifiers, stakeholders came together to pass the landmark 2019 law that implemented assisted living licensure and the comprehensive rights for residents. And again, as you heard, before the law was enacted, Minnesota was an outlier and the only state that did not license these assisted living facilities. MDH was responding to horrific reports of residents' abuse and neglect. And regulators and residents lived in a confusing world of housing with services, never knowing whom to hold accountable when something went wrong. So in the very short time the law has been in place, the law has protected elder and vulnerable residents who are better off since the passage of this law. Unnecessary evictions are way down, dementia training standards are in place, and MDH is enforcing basic protections, including ensuring that smoke alarms are working and fire and emergency safety procedures are in place. So as a coalition, we would be opposed to simply rolling back this law and exempting small providers because we really believe certain protections must apply to all residents, no matter how big the setting is. And so this has to be a discussion that we talk about from a resident viewpoint. But as you know, many of these small providers are serving the same population in terms of acuity, and so we do have to consider that these vulnerable residents deserve these protections too. However, you know, we have always been open to meeting with providers to understand the concerns and make reasonable changes if necessary. We're pleased to hear that the department wants to pull together stakeholders, and we are open to participating in that. And while we want to really applaud the department for all the work that they have done, we also believe that we should consider whether the state could offer more training and technical assistance resources, especially to providers who serve BIPOC communities, to better understand and adhere to the regulations. Lastly, while we know the challenges of the workforce crisis are a top priority, both for facilities and in-home providers, we really urge lawmakers to exercise caution and not respond to the workforce shortage by simply rolling back protections, but by providing the needed investments to this workforce. And we appreciated some of the comments that were shared by Ms. Sundberg. So thank you for your time, and we too look forward to continuing this important dialogue. Thank you.
Thank you, Mary Jo. I think we heard you loud and clear. I appreciate you. Always nice to see you. I was going to pull out my AARP card, but I didn't.
Okay. Wonderful.
I love it. So, and you know, since Commissioner, this is just, there's lots of discussion going on. One more person's, Zania Harut, right? Yeah, there. How are you? Come on up. And then if Assistant Commissioner, maybe we could spend just a couple minutes afterwards just having a, you know, so what's next kind of conversation. If you're thinking about that, I'd appreciate that. So, Ms. Harut, welcome. Nice to see you again.
Nice to see you again, too. Can you hear me? Yeah. Okay. All right.
You're good.
So, good morning, Mr. Chair and members. My name is Zania Harut, and I'm the board chair of the Residential Providers Association of Minnesota, also known as RPAMN or RPAM. I'm also a registered nurse and public health nurse, and I'm the executive director at Affinity Residential Care, Minnesota. So RPAMN is a 501c6 nonprofit trade association that represents small residential, customized living providers, licensed under assisted living, and waiver service providers in Minnesota. And we were formed in 2021 in response to a series of massive changes to the regulatory and reimbursement landscape in which our members operated. RPAMN has roughly 200 or so provider members and subscribers combined, with the vast majority being BIPOC-owned, Black, Indigenous, and people of color, for those who don't know, BIPOC-owned, culturally specific service providers who might not otherwise be engaged in the policy development and legislative processes. I'm here to talk to you today briefly about how our members have been, we believe, inadvertently caught up in a regulatory transformation that was never intended to include us, and the impact that, along with associated reimbursement decisions, is having on our ability to serve individuals in our community with disabilities. We have estimated over 600 BIPOC-owned assisted living facilities in Minnesota. And to start with some context, as you may all recall, in 2009, the Minnesota legislature authorized a moratorium on the growth of licensed community residential settings, or CRS beds, and directed DHS to reduce the number of beds in service by 128 beds. Not only did the moratorium freeze the number of licensed CRS beds, but it froze the demographics of those providing services. According to the Minnesota State Demographer, in the decade that followed the establishment of the moratorium, the state has added 5 times as many people of color as non-Hispanic white residents. Between 2010 and 2018, the fastest growing racial group in Minnesota was the Black or African American population, which grew by 36%, adding more than 96,500 people. The second fastest was the Asian population, which grew by 32%, adding 69,800 people, followed by the Hispanic population, which grew by 24%, adding 59,000 people. These demographic changes fundamentally change the profile of the individuals with disabilities needing CRS or other residential services, but unfortunately, culturally specific BIPOC-owned providers were generally boxed out of the conventional service delivery models. However, providers were innovative and began serving members of our own communities in single-family residential settings that were registered as housing with services facilities with MDH via the Comprehensive Home Care License. These services were then reimbursed as customized living for individuals under the CADI and BI waivers, as well as elderly waiver. This was the regulatory model that was also used for the larger residential providers, or the larger providers that we generally think of as assisted living, who were serving older Minnesotans, the senior community, in large apartment-style settings that were the industry that the legislature and MDH sought to regulate as you all developed the 144G assisted living licensure. The legislator never intended to include us single-family residential settings in its definition of assisted living. In fact, the definition of assisted living facility in section 144G.08 expressly exempts services in residential settings licensed under Chapter 245A, including adult foster care and services in settings governed under the standards in Chapter 245D. As such, many of the licensing and regulatory requirements established in Chapter 144G simply don't make sense when applied to a 4 to 5 bedroom single-family home and have been proven extremely burdensome to us, as others have described. I believe that the legislature recognized this, at least in part, when you all created a temporary exemption to the licensing moratorium in 2021, as it was explained to us, was supposed to allow a large number of the BIPOC-owned, culturally specific providers to transition out of the MDH customized living world and into the DWRS system, also known as CRS. However, the exception process has been extremely problematic for us, and that's a topic for another hearing. But further, the legislature's decision to expressly exclude BIPOC-owned, culturally specific CADI and BI providers from the rate increases supported by the increase in federal Medicaid matching funds for HCBS programs needed to respond to COVID and ongoing workforce shortages. And this has left our members on the verge of collapse. In summary, RPAMN is here, and we're here to represent hundreds of BIPOC-owned, culturally specific and language-specific disability service providers who are struggling to comply with the requirements of an assisted living license that was never meant for us. While trying to navigate the broken licensing and enrollment process to transition into CRS through DHS via the moratorium exception, all the while being the one collection of service providers who were excluded from the last biennium's rate increases, we hope that we can partner with you all to prepare for the 2023 legislative session.
Thank you.
And support us in the individuals that we serve in our communities with the resources and reimbursements that are appropriate to keep us afloat. So without that support, our members are destined to fail, leaving thousands of Minnesotans of color without the ability to receive support from providers in their own communities, speaking languages that they are used to and providing cultural services that are necessary for them.
Thank you, Ms. Harut.
Thank you.
I was on that. Representative Noor last year had a town hall on that. I appreciate you coming up here. I know Senator Abler wants to come in, and then Assistant Commissioner Stoll, thank you very much for your time, and we look forward to working with you because you're looking at the unique and individualized needs of a person with a disability and how that affects their livelihood. So Senator Abler and then the Assistant Commissioner, let's have a conversation about so what are we hearing, what are we doing, what's going on? Senator Abler.
Thanks, Mr. Chair. I'll throw my 2 cents. I really appreciated the testimony. I've been kind of working and then monitoring, and just to go back for the advocates, and I consider myself an advocate, Senator Hoffman, I consider you an advocate. for the elderly and people with special needs and wanting them to be above all safe and independent and served and, have adequate care. Nobody's suggesting a repeal, just so you know, and just so all the advocates know. But every period of time, we have to go back and, is it working? And if you have people sitting in a hospital that can't go somewhere that would be well suited by a smaller place compared to the large ones, and they're going to be closing or they can't support those individuals, then we have a problem. And what I'm getting from your comments, Mr. Chair, and just the general testimony is that, mostly we like it. We like it to protect people so that they're given service and they're screened and they're in the right place. But there has to be a practical way to handle this. And I don't think we can go back. If you have a 10-unit place, there's really no niche in human services licensure for those groups. You have a settings issue, and it gets controversial if you go above 5 or even
Some
5.
decision in 1998 called Olmstead, the Supreme Court made something on, so yes.
Well, right. But back when we went from 8 to 4, some of the advocates said, well, it's going to cost more and not be as good. And so there's a number between, anyway, so people are served well in these 5 to 10 unit settings, and we want to make sure that they can be served. And so how do we find the glitches there? And I think, Mr. Chair, under your gavel, we're going to be doing a lot of looking at that. So I think this is a really good part 2 of the discussion.
Yeah.
And I, for one, am eager to listen and find, is there something that's different from a small one than a big one? I'm curious about the maltreatment reports, what kinds they are. And if there's a certain kind of maltreatment report or underserved report from the smaller ones and the bigger ones, we should make sure that we control for that. So I'm going to sign off there, Mr. Chair, and I'll let you take it home after you talk to the commissioner. So thanks a lot.
Assistant Commissioner, lot going on today. Thank you for being here. Thank you for being really present with what's going on. And so what's Senator Abler saying? What are your thoughts?
Well, Mr. Chair and Senator Abler, thanks for this morning. This was exactly the conversation that we hoped would happen today, was having the provider perspectives and consumer advocates and agencies and others here raising both some specific issues that I think we need to keep talking about, but also reminding us of the bigger picture that we need to not lose sight of. And I really appreciated Ms. Schaller's presentation or her discussion around, how do you consider the needs and the complexities of residents and what the right path is for them, and have this bigger conversation that is not just about 144G. I think that was really obvious in many of the testifiers' comments today. So for us, I think our reaction is, for some of the specific things that came up today, specific pain points for certain types of providers, we're open to having that conversation. I know there have been bills that have come forward in the past to make modifications in some of those areas and didn't move forward for whatever reason, so we can keep talking about that. But we don't want to have just a piecemeal, let's tweak a little bit here, or let's tweak a little bit there, without having the bigger conversation about how we want to balance protections for residents, the care needs of residents, and the responsibilities for providers for all of the residents in the setting. So I think we can talk about the small pieces, but we don't want to lose sight of that bigger conversation at the same time.
Thank you. That's really, how do you transition that, right? How do you maybe we establish, I know Christy Grom has talked about how do you do transition grants or something out there to help support the industry. And I'm just throwing that out there, Assistant Commissioner, but clearly you've heard the different pain points, and I appreciate you acknowledging that. And one of the things that really gets me, that just kind of dealt in me in all my years of doing compliance for a certain law that was established in 1975. If anybody wants to look it up, Public Law 94-142, that was my background, right? I did that federally and did it at state technical assistance. The language in there that's still consistent to this day, 40-some years later, right, is that when you're talking about special education and related services for a child, the word is unique and individualized needs of that child and how that child's disability, the word they don't use effect, they used to say, access to the general curriculum, how it affects their education in the general access. But it comes back to that filter is if we focus on unique and individualized needs, that should come into the intersectionality conversation of if you have somebody that, has the cultural need, right? How are we being flexible as a system to make sure that we're addressing, because that's a unique need to that individual, and we have to be thinking intersectionality and not a one-size-fits-all type approach. And I think I hear you with that, and I appreciate you having that conversation. And I guess what's next is, let's this is the last the hearing for the year that Senator Ayler is going to have, and then I don't know what the jurisdictions are, but I know this is a passion of ours and a lot of people that we have, and I appreciate your leadership in this and hearing people and moving forward. So,
Thanks for creating the space for it today.
no, thank you. Any comments? Ms. Timian, you haven't spoken up. You want to speak up? She's like, all right. Toby, any last words? You're good? Thank you. Thank you, everybody, for being here. And with that, Senator Ayler, we say we're adjourned. Thank you.